Well, thank you, first of all, to the PMD Alliance for setting this up and allowing me to speak with you today about a really important topic, and that's changes in speech and voice and communication that can occur post-deep brain stimulation surgery. So just a little bit about myself. I am a speech-language pathologist. I have been part of the LSVT research team for 25 years. So it really is an area I went into right out of my master's school and through my PhD. I've seen tremendous advancements over the past 25 years in the care and management of communication for people with Parkinson's disease. But this is an area we still have a lot of work to do. So as Judy mentioned, I do have a slideshow. It'll take about 30 minutes, 35 minutes, and then we'll have time open for questions. So what I'm going to do now is just a few clicks to share my screen and get the slideshow up. Oops, I think I hit the wrong thing there. One moment. Share. Share. And then let's go here and let's see. Okay, so now you should have access to my slides, and I'm sure someone will yell at me if for some reason you don't. So again, I'm here today. I am currently one of the co-founders of LSVT Global and CEO. I'm also a faculty for LSVT LOUD and LSVT Big training courses, and spend a good deal of my time focusing on improving, again, communication, movement, and quality of life for people with Parkinson's disease. And today we're going to talk specifically about deep brain stimulation. The learning objectives are at the end of this webinar that you're able to describe some of the voice and speech changes that happen post-DBS surgery. Explain how speech treatments, in particular LSVT LOUD, may improve communication, and then outline some adaptations that may be able to facilitate and optimize positive outcomes. And we'll conclude with some of the sort of ongoing work that hopefully will give us better outcomes post-DBS for speech in the future. I do want to disclose to you my relationship with LSVT Global. In terms of non-financial, it's a preference for the LSVT LOUD as a treatment technique. And in terms of financial, I'm an employee of LSVT Global, and I receive lecture honorarium and have ownership interest. So let's begin. What is deep brain stimulation? I'm sure if you're tuning in, many of you are already aware of this, but in case we have any naive viewers, deep brain stimulation, or what I'll probably call DBS going forward, uses a surgically implanted medical device to deliver electrical stimulation to targeted areas in the brain. So it electrically stimulates specific structures that control unwanted symptoms, and in this case, in relation to Parkinson's disease. There are two of the most common placements of the electrodes for deep brain stimulation secondary to Parkinson's, and these are the subthalamic nucleus or the globus pallidus interna. You see here on the left-hand side, the GPI, or globus pallidus interna, is this yellow structure here. It's a larger nucleus. And on the right-hand side of your screen, I hope you can see my mouse here, you'll see the STN. And you'll see it's a much smaller nucleus that you have for targeting. So these are the two, again, most common areas. They're nuclei situated deep within the brain, hence deep brain stimulation. Once the electrodes are placed in the brain, into those areas, it's then connected to a neurostimulator or pacemaker that's inserted under the clavicle area. This can be done on one side unilaterally or bilaterally. And because you have, first of all, the neurosurgery to place the electrodes, typically it's followed by a second surgery to place the stimulator and the connection process, and then the adjustment of the stimulator process begins. Who are candidates for DBS? Typically, those who have a diagnosis of idiopathic Parkinson disease, so that would not include some of the atypical Parkinsonisms such as progressive supranuclear palsy or multisystem atrophy. Those who have had a robust and sustained response to levodopa medications are good candidates. Absence of dementia or unstable neuropsychiatric symptoms, absence of considerable surgical and medical risk factors, and those can be highly varied. And individual symptoms, needs, and goals should be considered in the target site selection, and that target site, again, being the GPI or the subthalamic nucleus or STN. In terms of what DBS can do to improve symptoms, it can reduce or control rigidity, the bradykinesia and akinesia, tremor, and dyskinesia. And these can all very positively impact quality of life for people with Parkinson's disease. It's suggested that typically it returns people to their best on time. And what that means is the best response that you get from medication pre-surgery, that's the likely target you'll get post-surgery, but oftentimes it allows you to reduce that amount of medication, and that sometimes can greatly improve dyskinesias, or those increased movements that individuals get secondary to medication. The target of the STN potentially has some side effects such as depression, apathy, impulsivity, worsened verbal fluency, and executive dysfunction. And STN or DBS is not as effective on gait, balance, or postural instability. There are some complications, and many of these that you see in the top half of this graph are really surgical complications. And these are related to potentials of hemorrhage or stroke related to the surgery itself. The two that I've circled at the bottom are ones that we as speech language pathologists typically take into consideration. And these are the potential for decline in cognition, and this has been documented in some longitudinal follow-ups, and possible decline in speech. Now, our rehab colleagues in terms of physical and occupational therapy also deal with the possible decline or lack of improvement in some cases in things like gait and balance. Dysarthria is a term that's often used to describe speech disorders or a collection of speech disorders. So dysarthria or speech impairment might be used interchangeably. So in this study, it looked at a multi-center study on deep brain stimulation in people with Parkinson's disease and looked at reported adverse events over 4 years. What this study did was compare the two targets of the STN versus the GPI. And what we see here is that this graph in particular is looking at speech difficulties, dysphonia, which would be problems with voice in particular, dysarthria more encompassing voice and speech, and that you see individuals with STN had a greater percentage of speech difficulties post-surgery than those with the GPI. So this goes back to what I mentioned earlier, that the GPI doesn't appear to have as many speech effects as the STN. But the STN, I believe in some cases, might be a more common target. So this is a consideration when we talk about what's the target for the therapy and what the percentage or change in outcomes might be post-DBS surgery. Tripoliti and Skoda both have published studies that have looked at what might be some pre-existing speech factors to consider that may contribute to the success or impact of DBS on speech after surgery. Tripoliti noted that lower preoperative speech intelligibility and longer disease duration may be risk factors for having difficulties with speech post-DBS. Skoda noted that a higher overall motor and speech scores on the UPDRS-3, and higher is a worse score, or a pre-existing speech pattern of articulatory slurring and hastening, or acceleration of speech. So those may all be considerations that put a person at risk for having speech impairment post-DBS. So let's describe a little bit about voice and speech changes following DBS surgery. We know that neurosurgical interventions in general do not consistently or effectively improve speech in people with Parkinson's disease. Now, while some studies have shown that components of speech may improve, for example, loudness of a sustained vowel, oral force control of the tongue, overall speech intelligibility is not necessarily improved. But the reports range widely. So speech problems or dysarthria that have been reported specifically post STN-DBS range from as low as 5% to as high as 61%. And we'll talk about why that might be so variable in just a moment. Some of these speech characteristics that the person with Parkinson themselves perceive were reported by Wertheimer et al., and this was following a survey study conducted by the DBS Alliance. And what they found that people post-DBS perceives, their perception and severity of speech disorders was greater in the DBS group versus people who had not had DBS. The people who had DBS self-reported more severe speech symptoms, reporting more symptom interference with social interactions and daily experiences related to functional, physical, and emotional issues of a voice disorder. Low voice volume was the most common speech symptom, and DBS had the greatest adverse impact on slurred speech. So this is a study that was first author, I may say his name wrong, Malnick et al. This actually came out of a group in Queen Square in London. The speech therapist who does a lot of that work there is Dr. Alina Tripoliti, but this is a research group that has probably done the most concentrated and systematic work looking at speech outcomes post deep brain stimulation surgery. And what they found is that a medial placement versus a lateral placement of the electrode can have an impact on speech outcomes. The medial placement being a more severe outcome than the lateral placement. So what I'll play for you first is the speech of an individual with a more medially placed electrode. And these subjects were from the UK, so you might notice a bit of a British accent. So I'll play the sample and then we'll talk about it.
I have freaking Lucy, Daniel, Jonathan, not necessarily in that order.
What order do you have them?
Daniel's the first, only say 2. Jonathan is the second, more loud. 9, and then we got Lucy.
And how many?
Lieutenant.
Nearly 36.
Yeah, that's right.
Okay, so you could hear really what I think you would agree is pretty impaired speech intelligibility. It's more of a strained and kind of tight sounding voice, inaccurate articulation. This perception of breathing insufficiency, and the idea is not having enough breath support. It's what we would classify as more dystonic. And unfortunately, it's less responsive to behavioral intervention. Not that it's not responsive, but it's not as responsive. So these individuals can be a bit more challenging to treat. And those perceptual characteristics that you heard in that speech sample are not typical of individuals just with Parkinson's disease who have not had surgery. So that's one type of presentation that we can hear post-DBS. The other type that they've characterized as more lateral, and it's all relative placement, is more classic idiopathic. And so I'll play this and then we'll talk about it.
Timmy's moving up to middle school in September. Luke is 13, enjoys playing football. Everything about football. collecting football cards, reading football magazines, and my daughter is the same. She plays football for Bedford Ladies, girls.
Okay, so this is a little more like what we hear pre-DBS. A softer voice, monotone, so not a lot of pitch inflection. The rate of speech may be increased, maybe reduced movement of lips and tongue, so not as clear of articulation. This is what we'd characterize as more hypokinetic, and often these individuals can respond well to LSVT LOUD, but they may have some added fatigue and some apathy that we have to contend with.
She may move out to
There we go. Triple ED and our colleagues have also looked at the longitudinal impact. So in this study, they reported on 32 individuals who had bilateral STN DBS at 1 year, 15 of them at 3 years, and they also compared them to individuals in a medical or no surgery group. Speech was assessed before surgery, post-surgery at 1 month, 6 months, 1 year, and 3 years. And what they found was that speech intelligibility deteriorated 1 year after DBS in 78% of the patients, which was in contrast to the same patients experiencing a 50% improvement in Parkinson motor symptoms. So this highlights this differential impact where movement might improve and speech does not. This is simply a graph of that same study I just mentioned, again, showing individuals pre-baseline, their speech intelligibility coming in about 70–75%. Immediately post in 6 months, so we don't really see an improvement, but what that study showed is then that over time, 1 year and 3 year, that speech intelligibility is deteriorating to where at 3 years, it's near only 50%. So this is something we don't want to have happen. Now, again, it's not a straight story on why changes in speech are happening post-DBS, and that's because there's a lot of factors that may be influencing this. So there's surgical factors, where the electrodes are placed, the setting of the stimulators, is it one side or both sides? How is that spread of stimulation affecting other structures in the brain? There's the medical factors, how severe is Parkinson's disease and the speech disorder prior to DBS. And then in terms of the studies that are reported, there's a lot of methodological considerations that sometimes make it difficult to compare one study to the other. So the selection and number of subjects in the studies, are they using a very specific speech measurement tool or a more broad tool like the UPDRS-3? And what's the time post-surgery in the studies? Because we could see if you're looking at 6 months versus 3 years, you'll have varying outcomes. So how might speech treatment impact individuals who have communication challenges post-DBS? Well, our focus for speech rehabilitation, first of all, is to maintain and improve the physical capacities. These are things like vocal loudness, voice quality, speech intelligibility, rate of speech. We want to maintain vital functions, and swallowing safety is always of key concern. Functional communication is where we're at. You'll see some of the exercises we may do are voice exercises, things like ahs. That's not the goal of treatment. The goal of that is to use that exercise to translate it into functional things. What do you say every day? What are the situations that are most important for you to speak in? We may need more than behavioral treatment. We may need external cueing. And this is reminders from people in your environment to use your loud voice or the strategy you worked on. Sometimes there are devices that could be helpful. The Speech Vive is a device that puts noise in your ear and helps trigger an automatic response to speak louder. The Speakeasy device alters your auditory feedback, which sometimes can be helpful for individuals who have a lot of stuttering type speech behaviors. We may need the assistance of augmentative devices. In some cases, we may need all of these. The good news is there's multiple ways that we can try to improve speech and communication for people with Parkinson's disease. And as speech language pathologists as well, we may need to address cognitive and or language deficits. And so our motto here is treat early and treat often. What I'm highlighting here very briefly is just that we have a very long history of scientific research, 30 plus years, starting from the initial development, funding through the National Institutes of Health, looking at randomized controlled trials, and a lot of data that we've studied specifically for LSVT LOUD. So this includes 3 randomized controlled trials showing the efficacy, and in this case, I'm talking in people not with DBS, but without DBS. And we spent a lot of years beyond that studying things like what happens to the brain, what happens to swallowing, facial expression, articulation, in addition to vocal loudness after LSVT LOUD. This could be perhaps a focus for another webinar, but today I just want to focus on what LSVT is briefly and how it may impact STN DBS. So LSVT LOUD is unique. It incorporates principles that drive neuroplasticity and really is designed to challenge the impaired system. 3 main concepts. We focus on vocal loudness or amplitude. So just like movements get small, the voice gets soft. So we use the cue of amplitude to override that and teach you how to have a voice that feels louder to you but is within normal limits. Making changes in behavior in anybody is difficult. With the progressive neurological disease, it's even more challenging. So treatment must be intensive and high effort. LSVT LOUD at a minimum dosage is 1 hour treatments, individual treatment sessions, delivered 4 days a week for 4 weeks, and we give daily homework and daily carryover exercises. And the third feature is it's more than a motor disorder, and really one of the greatest challenges improving communication in people with Parkinson's disease is that we can get you to talk louder, more clearly, but because to you it feels too loud, and that's due to a sensory mismatch, when you walk out the door, your tendency is to revert back to the soft voice. So through this process of sensory recalibration as part of our treatment, our goal is really to help you relearn a new way of speaking so that the treatment effects get out of the treatment room and into your daily life. One quick aside before I go on, because I forgot to mention this at the beginning, I will have a handout of these slides. I will send that to PMD and they will share that with you. So I apologize, I didn't say that sooner. Please know that you'll have access to these slides. So if you're taking notes furiously, you can relax and listen, and we'll follow up with the presentation. This is a snapshot of what a treatment session looks like. Again, I won't spend a lot of time here, but basically it's 2 halves. 1 half is our daily exercises. We see these as a core kind of rescaling of your voice loudness. The second half is completely personalized and individualized to you, in that we work on your long-term communication goals. And across the 4 weeks, we build up your endurance of speaking with good loudness for longer periods of times, from words and phrases to sentences, paragraph reading to conversation. But the materials that we talk about and the goals are personalized to you. So we have this core amplitude rescaling and then translation of that to functional, meaningful, individualized goals. Now, what are our data related to speech treatment outcomes with LSVT LOUD post-DBS? There are very limited research on any speech treatments post-DBS. In the case of LSVT LOUD, we have 2. We have a case series and a small group. Before I show those data, let me share with you a video of a woman post LSVT LOUD and DBS. So this is a woman who actually had LSVT LOUD very early in her Parkinson's disease when she was initially diagnosed, had a very nice typical outcome. Many years go by and eventually she does have DBS surgery. What you'll see in this video clip is her speech 5 years post DBS and pre a course of LSVT LOUD. Then you will see her post, and she had the 16 sessions of LSVT LOUD, and then the speech therapist added a few additional sessions with an extra cue of FAST to maximize her speech outcomes.
I knew the chance of slurred speech was great.
Okay.
But I didn't realize that that's what it was going to sound like.
Okay. So really be thinking loud and fast when you're ready.
Oh, my little kitten, how are you? Are you hungry? Hello.
What do you think?
I think that that's the best I've heard my voice in years.
Okay, so you could appreciate, I hope, that her speech is much more labored. She's working very hard, and that is not uncommon. Post-treatment, her speech is not perfect, but it's much improved, and she's got more confidence. That little cue of fast, loud and fast, in particular for her, was helpful. And she also learned some strategies to maximize, speaking at the times when she was less fatigued, knowing that sometimes it will be better than others. When we looked at our research study, we had a group of 4 individuals who were studied in our laboratory. In this figure, on the x-axis here is time, pre to post to 6 months. On the y-axis is a measure of loudness. So decibels is sound pressure level. So the higher up, the louder of the voice. This dotted line here are people who had no treatment. So we see no change over time. This dashed line are the individuals who had DBS and LSVT LOUD. And the solid line are individuals who had LSVT plus DBS. Oh, I may have got those backwards. The dashed line is the LSVT only. But what we see is the outcomes were pretty comparable for the LSVT DBS group and the LSVT only group with no DBS. And that's good news. But the clinical observations from the therapist was, without a doubt, treatment was more challenging. It was harder for those who had DBS to get the good voice quality. There was more slurring and impaired tongue control. And I think the video of the woman that we just saw shows that little more labored speech, and it was a bit more difficult to generalize outside of the treatment room. A study by Tripoliti and her colleagues out of London had a small group, 20 participants, and they were either what they called medical only, so they did not have DBS, or the surgical group who had DBS. These individuals then had LSVT LOUD and were measured pre, post, and follow-up. And they looked at a range of measures: acoustics, speech intelligibility, and some perceptual measures. This is a chart looking at the outcomes specifically for loudness. Pre, post, and follow-up. These are tasks. Phonation is just saying ah. Reading is reading a passage. Monologue is conversation. And while we see both groups made improvements, so the higher the number, the louder the voice, the only group that had significant improvements at post and follow-up were those that received LSVT LOUD. The group that received DBS did not have statistically significant improvements. Part of that was because it was variable in the response. Some people responded better than others. And then at follow-up, oftentimes those improvements were not sustained. So when we look at individuals post-DBS, we take each person as an individual. We can't necessarily apply our randomized controlled trial from the non-surgical group. And we've learned there's some subtle adaptations that we might be able to do in treatment that can be helpful. So adaptations are things such as increasing repetitions if durations are very short, allowing more rest breaks, recognizing individuals may be more fatigued, persisting at shorter levels of speech, phrase and sentence level versus long conversation, such as I am doing as I'm presenting here. We may need more family and support for carryover. If visual or language impairments exist, we alter our materials, and we may need more sessions. Alterations of LSVT or not, adapting the core protocol, doing shorter or fewer sessions, changing the treatment task, or eliminating specific exercises. To our speech therapist, we say, give everyone a chance. I would never discount anybody in terms of speech therapy simply because they've had DBS or even hearing very disordered speech. We say, come in and let's see what we can do. We recommend doing stimulability testing and at minimum a week of trial treatment. Sometimes we're amazed at the outcomes we can achieve. And that functional oral communication of any kind can often dramatically improve quality of life. So even if supplementation with some type-to-text augmentative devices may be needed for longer types of communication, but the ability to have some control over your environment with oral communication is huge. And what we know for sure, behavioral intervention is the most effective therapy for improving communication in people with Parkinson's disease, either with or without surgery. So our summary recommendations would be, first of all, let's see if we can optimize stimulator settings for speech. And this is where if the speech therapist and the person with Parkinson's disease can be active in the process when the neurologist and neurosurgeon are adjusting stimulation. We've had reports sometimes where, the focus is so much on movement, they forget to ask people to speak. And sometimes a balance has to be struck for optimal outcomes for both, or in some cases, there's a setting for speech and a setting for movement. Doing behavioral speech intervention. We recommend LSVT LOUD for 4 weeks, the gold standard. There may need to be additional therapy, additional follow-ups, or LSVT plus. Like you saw in that video clip, the clinician added a week of treatment with the cue of loud and fast. Maybe some of the devices need to be added. And when those very severe impairments from stimulation occur, again, we say trials of behavioral speech treatment, and let us throw everything we can at your communication to see what we can do to provide you some ability to communicate. Hopefully in the future, we'll have some advances that can improve outcomes post-DBS. I highlight a few. These are all very early studies and observations, but the adaptive DBS systems, which use feedback from the brain itself to fine-tune its signaling versus the constant electrical stimulation, may be a potential. Some individuals have noticed shortening pulse width, lowering frequency of stimulation may be better for speech, or it may be a combination of lower frequency, lower pulse width, and higher voltage settings. And these are things that are done, again, in collaboration with the neurologist who's doing some of the stimulator settings. Dr. Tripoliti and her colleagues have actually started to pre-treat with LSVT LOUD before DBS surgery. They're in the process of collecting data to systematically assess, does that make a difference or not? Dr. Tripoliti's clinical sense is that they've had a lot of good outcomes and improvements with that pre-treatment. It doesn't mean that you won't need some speech therapy after DBS, but the impact of the speech therapy after DBS when people have been pre-treated appears to be better. And then another tool is actually voice banking. Voice banking is the ability to record your voice and preserve it for future use if needed. If it's not needed, no problem. An organization that does this is Vocal ID. I've put the website there, and you can certainly learn more. But if you're doing LSVT LOUD pre-DBS, banking your voice as an exercise with Vocal ID, it costs nothing to bank your voice, and it provides voice samples for other people who may need it. And then if something should happen that perhaps you need some type of augmentative device, your voice is banked so that the device can sound like you if needed in the future. So in summary, so that we can get to your questions, voice and speech changes can occur following DBS. Behavioral speech treatments such as LSVT LOUD may improve communication. Adaptations can be made that facilitate and optimize positive outcomes. And we look towards future research to help improve outcomes for people post-DBS and for behavioral speech treatment post-DBS in the future. I know we'll go to some live questions now, but I'm also sharing with you information on LSVT Global, as well as my email address. So if there's questions that don't get answered today, you'll have this. Again, we'll send you these slides for the future and can ask more questions as they come to you. So now I believe what I need to do is stop sharing my screen, and I'll turn it back over to Judy.
Okay, Cynthia, thanks so much. That was a lot of great information. And we did have some questions. Before I go to them, I just want to tell everyone that we will, as Rebecca mentioned, we will have a PDF of your PowerPoint presentation. And if you email us at info@pmdalliance.org and request that, then we can send it out to you. Also, we've recorded this session, so at the end of it, Rebecca will take it, and it should be on our PMD Alliance YouTube channel by Thursday. So you can also go back and look at it again or share it with other people. Now, as Cynthia, as far as some questions, I've got one here from Paul, and he's asking any resources to recommend for effective DBS on athletic performance, especially coordination in skiing.
Now you're stepping a little out of my scope of practice because I'm the speech language pathologist, but I do work a lot with physical and occupational therapists. And I think, you know, that you've got very individualized goals that you want to do. I would recommend in your case, you know, seeking out a physical therapist who has expertise in Parkinson's disease. These individuals range. I know that the PD Foundation has people who have taken their specialized training. Obviously, we have LSVT Big certified therapists. I know that the PMD Alliance has a list of people who do exercise groups. So there's a lot of different individuals who train specifically for Parkinson's. So I would seek a physical therapist that has some expertise in Parkinson's disease. They likely would do an evaluation. They take into account your very specific individual goals and would work on exercises, hopefully that could help improve you, because always our goal is to help you keep doing the things you want to do, whether keep doing them or get back the skill to do them as well. So it would definitely be worth pursuing that line of seeking a physical therapist for your goals.
Okay, thanks, Cynthia. And everybody, I think we've unmuted all of you, so you can also just ask your questions into the speaker on your computer and we'll be able to hear you. Let's see, let's look at another question. Is LSVT treatment available online?
We do have some therapists who deliver telepractice. And so again, in our database, or you can email us at info@LSVT Global, we can look to find if there's speech therapists who do the treatment online. We love telepractice. It's a phenomenal way, and it breaks down a lot of the barriers, like geographical barriers, even if you live in a big city, sometimes to travel to the clinic can take an hour to get there, have therapy an hour back. So yes, we also have, what's exciting, are research studies that show the effectiveness of the treatment is as good via telehealth as it is face-to-face. Reimbursement for telepractice is variable. Some private insurances absolutely cover it. Medicaid in certain states will cover it. Unfortunately, at this time, Medicare does not cover telepractice services for any of our rehabilitation. So that includes speech, physical, occupational therapy, as well as audiological services. You can help us join the lobby to make that change. I think, you know, it should be covered. I hope that it's coming in the future, but that's a consideration. So if Medicare is your primary insurance at this time, it does not cover telepractice services.
Okay, great. We've got a question from Harold, and Harold, your question is complicated enough. Do you have a mic where you could just simply ask Cynthia directly?
Well, can you hear me?
Yes, we can.
Okay, let me explain. I have hearing aids, and my hearing aids are Bluetooth compatible, meaning I can hear my phone. I can hear through my phone ring and my phone talk and everything else. And there are also microphones that are Bluetooth compatible.
Mm-hmm.
My question is there anything where my wife could wear a microphone, one of those small mics, you see the people on stage wear, so that I could hear her talk, and also because of the Bluetooth, I can also get it directly into my ears, directly in that way, or even through my phone to her. Because I also notice when you put a phone in front of her, her volume is almost double what it normally is, and the speech is slower and better articulated. It's like magic. I don't know how to describe that, why or anything else, but she is, post-DBS, and she had no speech problems whatsoever prior to DBS.
Yeah, a great question. I don't honestly know, but that's a fascinating idea about Bluetooth device for a microphone. There may be just some commercial off the market things that could do that. I know there are a number of different devices, and I can certainly share this information as well afterwards, that are amplification devices. And some of them have actually been studied specifically for speech in people with Parkinson's disease, which devices are better, which are not. Whether or not any of those are Bluetooth, they may have not been Bluetooth compatible when the study was done, but technology changes so fast, potentially they could. One of the cautions always with amplification devices is you're amplifying a signal. And so if the signal is noisy, so if it's a breathy or hoarse voice, imprecise, kind of like static in your radio, you're simply amplifying that.
Yeah, I worked for 30 years with AT&T. I'm familiar with all of that.
Yeah.
It's garbage in, garbage out, basically, is what it comes down to.
But the combination sometimes, they can still be helpful, because even with behavioral treatment, that the amplification can sometimes add a little bit more, especially at times when people are particularly fatigued or it's super important for them to be heard. And
there's all sorts of voice filters that you can work on those with that are already into most hearing aids, et cetera, and are tunable.
Mm-hmm. Yeah. Now, regarding your observation that when the phone is in front of her, she improves, we would call that an external device. It's almost like external cueing. I would say it's not unlike, people, if their lines on the floor, their gait can suddenly normalize. So it's providing some external cue that for some people can be helpful. The challenge they're great, but the challenge is, the cue has to be there, and it's not always there. And then sometimes it works for a while, and then that effect diminishes as well. But again, this speaks to multi-levels of treatment, behavioral treatment, as well as sometimes pairing these other tools and strategies to help as much as possible.
Oh, that's good.
Thank you.
Great.
Hey, Cynthia, we have a question. What if your problem is that my upper lip doesn't move?
Mm-hmm. Yes. So masked face is very common associated with Parkinson's disease. So it's a combination of not just the upper lip. In many cases, the entire face does not have the same level of expressivity. There's very little evidence showing that really much of anything improves facial expression in people with Parkinson's disease, but people are looking at that. One of the things that we've noted with behavioral speech treatment, in particular LSVT LOUD, is that when we're driving vocal loudness, and again, it's always healthy vocal loudness, that effort spreads across the entire speech mechanism. Mm-hmm. And so that we not only see that the voice gets louder We can measure elements of articulation improve, and certainly speech intelligibility. Now, one of the few studies that actually has systematically documented improvements in facial expression is post-LSVT LOUD. And that what's interesting is we did a randomized trial where we looked at the voice therapy compared to an equally intensive, what we call articulation therapy, that had a lot of exercises that were more related to lip-tongue control. And only the voice treatment loud changed facial expression. One of the reasons we think that's true is that voice is very tied to what we call phylogenetically old neurostructures in our brain. They're very tied to emotion. So that when we're using voice as this target, yes, we're addressing a problem in people with Parkinson's disease, the soft voice, but it may be triggering a lot more. So it may be a very efficient target for improving not only loudness, but speech clarity, but we see some of these changes again as well in facial expression.
Okay. I know myself, I've noticed with people post-DBS, and then also just with LSVT, that as their ability to speak improves, it seems like their whole mood and confidence improves along with it. I can't help but think that it just feels a whole lot better to know you can talk and participate, and people understanding what you have to say. So.
Yeah, absolutely, absolutely.
Okay, oh, it looks like Kathy unmuted her mic. Does that mean, Kathy, you want to ask a question or make a comment? Maybe not. Okay. Any other people who have questions for Cynthia or comments? Okay. Cynthia, I've got one question.
Sure.
And it's in relationship to fatigue. That, you know, sometimes I know when I'm talking and, you know, really paying attention to what I'm saying, maybe I'm presenting something, you know, it can be tiring. Is it more tiring? Is speech and conversation more tiring for someone with Parkinson's, either with or without DBS?
Yes, that fatigue is real. Fatigue, generalized fatigue associated with Parkinson's, and then vocal fatigue can happen as well. Some people know. I mean, again, there'll be people who don't, you know, have minimal challenges, maybe not experience fatigue, but definitely we can see an impact, and that impact can be at several levels. Sometimes the fatigue is real vocal fatigue. I know that sometimes people who are still working full time, they have to use their voice all day. They can do it, but the cost is when they get home, they basically want to shut down and say, I'm done talking, I'm tired, I can't communicate anymore. Which troubles us, because when you get home, those are really important people to still be able to talk with. So sometimes the speech treatment earlier than later can help give you techniques, strengthen your physiology, so perhaps you don't have to experience so much fatigue. All of us, whether we have Parkinson's disease or not, with DBS or without, can experience fatigue, you know, mental fatigue. And sometimes that fatigue is more of a communication issue, in the sense that word finding can be more challenging, losing your train of thought, and those can be frustrating things. And then fatigue, for sure, post-DBS, in certain people, it can be a real challenge. And that's where working with your speech therapist, not only to try to improve, you know, the physical capacity, but also strategies for communication that go beyond that. Or, you know, when is it most important to communicate? How might you save up certain times a day when you know you're better, and say, okay, this is the time of day I need to schedule my phone calls, I need to schedule my meetings or social activities. So it's a challenge, but we do have some strategies that can help.
Okay. Does anybody else have a question?
I do.
Okay, Bob, what's your question?
Okay. I, in a process of having a workup for asthma and allergies, my doctor said that I most likely have PVFM, paradoxical vocal fold motion.
Yep.
Otherwise known as VCD, or vocal cord I don't know, is it dysfunction or disorder?
One of the two.
One of the two, okay.
Yeah.
VC, that thing.
Yes.
Okay, and he's referred me up to OHSU. I live in Southern Oregon, and he's referred me up to OHSU to some speech professionals within the Parkinson's Center of Excellence.
Yep.
And when he also sent me to an ENT who was able, the only one in this area who's able to do video stroboscopy.
Mm-hmm.
And he saw that my false vocal cords, and I even, I thought I only had real ones. I don't do falsies, I'm dating myself, huh? But the false vocal cords were almost completely occluding the real vocal cords, and I could see that on the video. There was just a little space that you could see the real cords. And I'm just wondering what you think about that. Yeah, I'm going for all kinds of workups and yada, 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 but you can hear my voice right now. Or maybe you can't, but it's, this is not what I usually am. As a matter of fact, I used to be a trained opera singer.
Okay.
And so this is a monumental major drop for me.
Right. No, I understand. Yes. So you've got multiple things happening. Likely you've got maybe some changes with Parkinson's disease, but also the PVFM, and the false fold overclosure. Oftentimes that is what we call a compensatory mechanism, that sometimes if the true vocal folds, and this can happen in Parkinson's disease even without PVFM. And so sometimes when the true vocal folds aren't closing all the way, the voice gets softer. We overcompensate, we drive with effort, and that can be where the area above the vocal folds starts to squeeze together as well. I'm not a PVFM expert. I'll qualify that. I do have a great person who is, so I can get you more information offline if you like. She's both LSVT and a PVFM expert that could give you some advice. But I can say that we've noticed that individuals with Parkinson's disease and the false fold overclosure actually get better after treatment. So because we can, with these exercises, improve true vocal fold adduction, some of that squeezing and that compensation relaxes. And that, that's a vocal fatigue that comes from doing things the wrong way in some cases. And even though the exercises are a lot of work, post-LSVT, people feel less fatigued. What I don't know, and
you mean I got to work? You mean I got to work?
Some exercise. Yeah. What I don't know off the top of my head is that if there would be direct PVFM strategies that would be in place, perhaps control of asthma and the allergies first before LSVT, or that sequence, and that's where I would work with the PVFM expert therapist who knows that. And it sounds like you're on your way to a clinic that can help you, but I can reach out to my colleague as well offline and see what else I can provide for you.
My gut feel is that there's a Parkinsonian element.
Oops. Okay.
My gut feel is that there's a Parkinsonian element to this.
Okay. Yep.
And I have communicated with many people across the country, professionals, and no one has any studies that correlate or relate Parkinson's with PVFM. And maybe your person can shed some light. Would you like me to send you my email address, or can you get it, or how does this work?
Bob, why don't you send Cynthia your information and remind her of the topic, and then she can get
Sure.
Yep, I'd be happy to. Yeah.
And I really appreciate that. What is your information?
It'll be on the slide set that will come.
Okay.
And so it's just my name, Cynthia.Fox And then it's at lsvtglobal.com.
Okay.
Okay, so we had, let me see,
Thank you.
You're welcome.
Kathy has been waiting. Kathy, I saw you pop in and pop out. Do you have a question? Kathy? Uh-oh. All right, let's go on. We've got one, the cost of LSVT LOUD and where I can find it.
Okay. We have on our website a database of therapists who've been trained, and the website will be on the handout as well. It's lsvtglobal.com. There's a big orange button that says Find LSVT Clinicians, and then you can type in your zip code and look to see if there are therapists in your area. If you're not comfortable with that, you can call our office or email us, and we can help with that as well. The cost is dependent upon where the person works. So it would be typical of a cost of any speech therapy session. And depending upon the facility someone is working at, whether it's inpatient, outpatient, home health. Typically, if your insurance plan covers speech therapy, LSVT is just a type of speech therapy, so it should be covered under that umbrella. So those would be questions to address specifically with somebody in your area and at a facility that's available to you to go to for rehabilitation services.
Okay. One more, and we'll take just a couple more and then we'll need to wrap it up. But I've got one here that says, if someone works in a profession where their voice is crucial, would you recommend putting off DBS because of the risk of the voice being impacted?
You know, I would say I wouldn't make a recommendation one way or the other, but I would say the most important thing is that when you're having those conversations with your neurologist, with those involved in the DBS team, that concern is very much voiced. And so that everybody is aware that may impact when surgery occurs, the target of surgery. It may be a case where you would want to have the pre-LSVT LOUD potentially to kind of toughen up those circuits before surgery. So I think those are important conversations because typically it's more than voice when someone's considering DBS. But it is really important that your concern is brought to the forefront, and reaching out for more information. Again, on our website, we have more information. You can email in, we can provide more to help answer those questions for you.
Okay, here's another one. Had DBS a year ago. I don't have any voice issues. Will I have it later? I'm an opera singer and very apprehensive of this possibility.
Not necessarily. Again, DBS has a different, course. That's great that you've kept your voice. Probably the fact that you do a lot of vocal exercise, my guess, has played a role in keeping your voice strong. I think we always tell people, be vigilant. One of the key things with speech changes in people with Parkinson's disease, the person themselves feels like it's always felt. Oftentimes they feel like they're loud enough, they don't notice changes, but suddenly people around them are saying, what did you say? I didn't hear that. And the classic is, my voice is fine, my spouse needs a hearing aid. While that may be true, there is a sensory mismatch. So I always tell people, you have to rely a little bit on the environment around you to tell you if things are changing. If you notice changes, the sooner you can engage in speech treatment, the better. And so keep your voice strong, learn the exercises, and if you keep doing them, it may have the potential to keep you on a path of solid, good communication for as long as possible.
Okay, just two more and then we'll need to kind of wrap up. First one is, can Parkinson's affect the singing voice? And
yeah, absolutely. Because if it affects the voice, you're affecting somewhat the physiology that can, be used for singing and for speaking. Sometimes we think of speaking and singing really as two different circuits. Even though it's using the same mechanism, the drive for that may be different. Some people notice less problems when singing versus speaking, vice versa. We know, for example, in other challenges like stuttering, often people who stutter when they speak don't when they sing. So if you want to improve singing, singing exercises are great. If you want to improve speech, speech exercises are important. And that's kind of a concept of specificity of training. Recognizing as well, there's some overlap. And so if your muscles overall are healthier, you may see some impact. So it can have an impact, and speech therapy could help. Specific singing voice lessons, in particular if it's your job, can be helpful as well.
Okay, thank you. One last question, and this is in regard to family members or care partners. What can we do that can help a person who may be having some difficulties with volume or being articulate? What can we do that would be helpful to them, and maybe a good approach for how we can do that?
Great question. I think one thing, first of all, is to recognize the source of the soft voice and that it is part of Parkinson's disease. I always want to educate both people with Parkinson's and care partners of the sensory deficit, and to really recognize when the person with Parkinson's disease is speaking in what you may perceive as a soft voice, oftentimes to them it feels normal. So when we get them louder, that you go, wow, that's normal, to that person it feels like they're shouting. And that's why it's difficult to do. Because if I told you, walk around and feel like you're shouting, you would be, that's not normal. That's why the speech treatment is so important, because we spend a month and all kinds of activities to really try to help retrain the person's perception, their brain, that what feels too loud is actually within normal limits. That being said, sometimes cueing to be loud can be helpful, but I'd say have the conversation. Ask your spouse or family member, you know, I'm having a hard time hearing you. When is it okay for me to cue you? You know, if somebody's being cued and nagged all the time, that can almost work against, you know, having a positive impact. And then I'd say collectively learning more, you know, webinars like this where you learn more. We have webinars on our, you know, website as well that are free, on demand, live in person, having those conversations, and then finding speech treatment and saying, you know what, it might be time that we get in there. Let's get your voice back to where not just me, but everybody can understand you and hear you better.
Perfect. Okay. Well, Cynthia, thank you so much for sharing all your expertise and great experience with us. Everybody, I just want to tell you, if you can't see the screen, you can reach Cynthia at cynthia.fox@lsvtglobal.com. You can reach us at PMD Alliance at info@pmdalliance.org. And our YouTube, if you just Google PMD Alliance YouTube, you'll find that we have quite a library of videos on different topics that you can watch. And Cynthia's should be on our YouTube channel on Thursday, if you want to take a look at it again. So I want to thank you all for coming. Cynthia, thank you so much.
My pleasure. Thank you.
Yeah, we really appreciate it. And I want to tell you all of the experiences that I've had with people who've had LSVT. Wow, you know, what a great therapy for people with Parkinson's. So everyone, have a good day, you know, and we'll see you next time.
Great. Thank you.
Thanks so much.